bridge. So to overcome this, there is okay. Come to the terminology implant. What is implant? Implant is any object or the material. Okay, it is any material, maybe alloplastic, xenograft, substance or the other tissue, which partially or completely inserted और ग्राफ्टेड इनटू द बॉडी. ओके, मैंने कोई मटेरियल लिया, उसको ग्राफ्ट कर दिया बॉडी के अंदर कहीं पे भी, आइदर फॉर द थेरेपेटिक पर्पस. फॉर एग्जांपल मैंने कोई स्किन ग्राफ्ट लिया, यहाँ पे नहीं था मेरा ग्राफ्ट, लेकिन मैंने यहाँ पे लगा दिया. तो फॉर द थेरेपेटिक पर्पस और फॉर द एस्थेटिक पर्पस, फॉर द एक्सपेरिमेंटल पर्पस मैंने कोई मेटल लिया, मेटल को लेके किसी एनिमल जॉ के अंदर लगा दिया. ठीक है, एंड देन वी रिव्यू इट, आइदर व्हाट इज एक्ट एज अ फॉरेन बॉडी ऑब्जेक्ट or it is taken up by the body. If it is taken up by the body, that means it is biocompatible. Correct? For example, the gutta percha we are using in RCD, it is a biocompatible material. That's why we are using lot of the maximum number of times gutta percha into the for the RCD. On the same way, in an implant, the titanium material is a biocompatible material and it having the most important property of osteointegration with the bone. So that's why the implants are basically made up of the titanium, either it is a type 4 or type 5. So for the diagnostic purpose, prosthetic or the experimental purpose, dental implant can be defined as the substance that is placed into the jaw, because we are talking about jaw. So dental implant is basically placed into the jawbone, okay, to support a crown, a fix or the removal denture. So in the implant also, there are a type of different type of processes. Removal fixed denture. Removal fixed denture are come under the semi-fixed denture, in which we are putting minimum number of implant, and over that we can put a removal partial denture. So it will provide the stability as well as retention. According to the prediction, it is an alloplastic material implanted into the oral tissue beneath the mucosa or the periosteal tissue or within the bone. So there are different type of implants. Some implant we are placing inside the bone, some implant we are placing above the bone, just below the mucosa. That is called as either submucosal implant or subperiosteal implant. If it is below the periosteal, above the bone, that is called as subperiosteal. If it is above the periosteal, it is called submucosal implant. Okay? And if it is inside the bone, then it is called endoxious implant. Okay, so according to them we can categorize the implant system. This is the history we already discussed. There is a long back history. Some people use the extracted tooth of other human donors, but the main disadvantage is extremely low rate of success due to the strong immune reaction. In 2500 BC, some people are using the ligature wire for the missing tooth rehabilitation. In 600 AD, the Mayan population used the piece of shell in place of missing tooth. Then the subperiosteal type of implant is given by them. And these implants are subperiosteal, that means the implant are placed just below the periosteum. The main disadvantage of this type of implant is because it is not inside the bone, it is above the bone. It is take a rest over the bone, but there is some micro movement, and during the forces there are some friction over the soft tissue. So most of the time inflammation is present around these implants. That's why nowadays these type of implants are not commonly used. Then in 1980, the Tatum is the first titanium root form implant. Why it is called as root form? Because if you see the root structure, the shape of the implant, it is almost like a root of a natural tooth. So that's why it is called as root form implants. The subperiosteal, then the endosteal blade implant, it is given by the Limco. It is very popular in that particular time in 1960s, the Limco's blade implant. But disadvantage is there is a long blade present at the apex. So for the stability of that implant, we have to remove a lot of bone from the jaw and then we have to place it. Okay, so that's why these implants are also not used nowadays. Then come to the famous person in the implantology, also called as the father of implantology, the Dr. Brainmar. He gave a concept of osteointegration. The lecture is taken up by the Dr. Sumit Malhotra sir on the osteointegration. He will tell you about in detail about the osteointegration. But it is a quantum leap in oral implantology was achieved in 1952. It is a Sweden's orthopedician. What he did experiment on the rabbit, he put a titanium screw and put it in a jawbone and sacrificed after the 3 months. Okay, and then he accidentally find out the around the titanium screw there is a more bone growth. That means the bone is completely entangled around the titanium implant, and it is very difficult to retrieve after the sacrifice, after the cutting the bone. Then it is give the concept of osteointegration. So for in implant dentistry, the success rate of implant is basically dependent on the osteointegration. The osteointegration is basically defined as the direct contact between the bone and metallic implant. So we have a titanium implant, we have a bone, osteotomy. If there is a direct contact of the bone with the implant, it is called as osteointegration. That means the survival rate of implant is very, very good. But if there is a fibrous tissue formed in between the implant surface and the bone, then it is called as fibrous osteointegration or the fibro-osteointegration, and there are higher chances of implant failure. Okay, so for any implant success, we need osteointegration, and titanium is one of the material which having a good property for osteointegration with the bone. Then we come to the rationale why we use implant. What is the evidence base? First, in the implant dentistry is a boon for restoration of missing tooth. It is correct because nowadays there are a lot of missing tooth. If you see the extremes of age, अगर आपके पास ओल्ड पेशेंट कोई आता है तो मैक्सिमम नंबर ऑफ टाइम आइदर वो पार्शियली डेंचुरस होता है या कंप्लीटली डेंचुरस होता है, ठीक है. एंड लाइफ एक्सपेक्टेंसी इज आल्सो इंक्रीज नाउडेज. पहले होता था 50-60 ईयर हुआ, नाउ बिकॉज ऑफ द मेडिकल improvements and the other dietary conscious patient, the life expectancy is more nowadays, and because of that the implant dentistry is flourish. Okay, everyone wants an implant which is fixed in nature. Okay, so that's why it is boon for the restoration of the missing tooth. So that is the first rationale. Second is to overcome many disadvantages of other conventional method of restoration. For example, removal of the fixed prosthesis we already discussed, because there is a problem of retention, there is a problem of mobile tooth, there are a lot of problems with the denture and the prosthetic during the mastication. Then sometimes it is not getting a proper stability and the retention. To overcome all of these problems, we have a new option, that is the implant. The third one is, it is a unique tissue ability to achieve replacement of the teeth regardless of the atrophic disease. Sometimes we have atrophic maxilla. Okay, because if you know the resorption of the bone, I think prosto में आप लोगों को पढ़ा होगा resorption. In maxilla there is a centripetal resorption. That means the bone is resorbed upward and backward. ठीक है, इसलिए maxilla छोटा होता चला जाता है. Maxilla is resorbed downward and outward. That is a centrifugal resorption. तो अगर आप किसी E-dentulous patient को देखते हो, it will looking like a skeletal class 3. देखा denture बनाते हुए टाइम देखा होगा, तो most of the time the E-dentulous patient is looking like class 3 patient. Second is because of the sinus in the posterior maxilla. Once the tooth is extracted, there is a continuous resorption of the bone, annular bone in the width and the height, and on the same time because of the sinus pressure there is a pneumatization. So there is very less amount of the bone in the posterior maxilla. In that particular case, nowadays we have advanced implantology. Like for example, if it is not present, put a conventional implant. In that particular cases, we can put a basal implant or we can put a jagomatic implant. But we can give a fixed prosthesis to the patient in any atrophic jaw bone. Then injury to the stomatogenic system. Sometimes there is a neuro. That particular case is also the implant is the main source of fixed prosthesis. Then we come to the scope of dentistry and implant in dentistry. The first is prosthetic rehabilitation of the missing tooth. Rehabilitation of the complete E-dentulous maxilla or mandible. For example, in the first, if you see, it is a complete E-dentulous patient. We are putting multiple implants in the jaw and then we give the fixed prosthesis. Okay. On the same way, if the arch is the bone is very less and patient is not ready for the multiple implants, then minimum 2 implants in the mandible and 4 implants in the maxilla. If the bones allow, then we give it to the patient and then put removal semi-fixed type of prosthesis to the patient. Then the partial dent. In this particular case, we are not able to give the RPD, correct? Kennedy which classification? One side detention in the posterior back. So in these particular type of cases, it is very difficult to give RPD. If you are giving a RPD, then you give a wire, and that will take a support adjacent to, and that it will create a fulcrum at that particular area, and after some time that tooth is also mobile. Okay, so in type of cases we can also give an implant as a fixed prosthesis. Single missing tooth. Single missing tooth, if you bridge, we have to cut this tooth as well as this. Okay, these two tooth are the sound tooth. If you are cutting this intent of the ear not there, then we should hide and it is fixed with the help of implants. Then nasal prosthesis. Okay, most of the time the gunshot injury or any damage or any animal bite, sometimes the nose is not there. So we can artificial nose as a fixed prosthesis with the help of implant. Then for the rehabilitation of the congenital developmental defect, I think everybody knows about the cleft lip and palate. In the cleft lip and palate, there is a bone quality is not good. There are some missing tooth, especially the canines. If it is a alveolar defect also, then in these particular type of cases we can rehabilitate with the help of implants. Second is ectodermal dysplasia. In ectodermal dysplasia again either there is a oligodontia or aodontia. In these cases we have to rehabilitate with the help of implant as a fixed prosthesis. Then complex maxillofacial defect, especially in the mucormycosis after the COVID, we have a lot of cases regarding the mucormycosis. We can fix with the help of zygomatic implant. And nowadays, orthodontic anchorage we also take with the help of dental implants. Then we come why the implant is preferred over the denture and the bridge. The first and most important is stability. If you doesn't get the stability with the help of RPD or the denture, the implant is the best option. Second, if you putting a zirconia crown above and the denture with acrylic, they are wear and tear of adjacent or the healthy. Second, chewing efficacy. Chewing efficacy in RPD is less, denture and the implant. The implant having the same chewing efficacy as compared to the denture and the RPD. According to the literature, if you see, 80% more as compared to the RPD and 70% more as compared to the crown and bridge. Then protection of the jawbone. If you are putting a denture, there is a continuous loss of the bone because it is a physiological process. But if you place an implant, there is a stimulus which increase the osteoclastic and the osteoblastic activity, and the bone turnover rate is equal if you are placing an implant in this jawbone. So there is a protection of the jawbone and there are very less and then the eating habits. Implant you can eat whatever you want. Okay, because the efficacy is more and it is more as compared to other treatment modality. Advantage, maintain the bone and height, we already discussed. Then maintain the facial aesthetic, improve phonetics because it is a fixed, then improve occlusion, we can improve the occlusion with the fixed prosthesis, increase the prosthetic stress. We are replacing if it is a single tooth replacement, we are replacing a single missing implant. If it is a multiple, we are divide the force in a multiple implant. Improve the masticative function, improve the stability and the retention of the removal processes. If the patient is not on the multiple implant, then we put 2 or 3 implant and put a removal denture over that, and it will increase the stability and retention. There is no need to alter the adjacent teeth, more permanent replacement, and improve the psychology of the patient. Disadvantage is the very expensive. Previously it is very expensive, but nowadays there are a lot of companies in the market for the implant. The cheaper implant is also there, but we can say it is expensive than the other treatment modalities, for example, the complete denture or the removal partial denture. Cannot be used in a medical compromised patient who cannot undergo surgery. Previously, there are a lot of literature regarding the diabetic patient, regarding the smoking patient, regarding the osteoporosis patient, regarding the osteoarthritis patient. But now, the two type of patients are basically contraindicated in cases of the implant. One is if patient having a osteoarthritis. Okay. Second is if the patient is uncontrolled diabetic or any uncontrolled disease, and third is smoking. If the patient is not able to stop the smoking after the counseling, then never put an implant in cases of smokers. Duration of a treatment and tedious fabrication procedure, definitely, because once you put an implant, it will take time for the osteointegration. So mostly the 3-month time is required for the osteointegration. So then there is the first surgery at time of implant placement, then after the 3 months we have a second surgery, and then the prostate fabrication. So it will take around 4 to 5 months for the compromise of the denture support area. Okay, if you are not able to make a denture, then you go for the implant. Unrealistic prosthodontic expectation. Sometimes patient want मुझे तो ऐसा डेंचर चाहिए, फिक्स चाहिए, निकलना नहीं चाहिए, टंग से बाहर नहीं आना चाहिए. In this particular type of cases, you can go for the implant. Psychological inability to wear a removal prosthesis. कुछ लोग होते हैं जो नहीं पहन पाते, जैसे ही उन्होंने पहना बाहर निकाल देते हैं. It is not acceptable. So in these cases, the implant is one of the treatment modality. Then single tooth loss to avoid involving the neighboring tooth. Aesthetic zone, definitely implant is the best option. And the preserver interdental diastema is also one of the indications for implant placement. Absolute contact indication, these are the previous one, but now the absolute contraindication is any uncontrolled disease. Either it is uncontrolled diabetes, uncontrolled liver or the kidney disease. If the patient is immunocompromised, or if the patient is not able to stop smoking, or ORL, okay, in these particular cases we are not putting an implant. The related contraindication, recent myocardial infarction, definitely absolute contraindication, but after the 6 months of the treatment, you can put implant in myocardial infarction patient. Systemic hematological disorder, if it is controlled, you can put. Irradiation of the jawbone, you have to wait for 6 months in these type of cases, and then you can put an implant. Control liver and kidney disorder, osteoporosis. Osteoporosis patient, you can put implant, but you have to check or investigate the patient for the calcium and the vitamin D level, and then you go for the implant placement. And if there is a local pathology, you can remove the local pathology and then you put implant. Now we come to the classification. I am just touching the classification. What are the different type of classification we have? The first is given by Babush. The classification goes based on the implant design. ठीक है? Endorsal implant कौन से होते हैं? What are the endorsal implant? अभी बताया था. It is a root form implant. It is going inside the bone. Second is subperiosteal, means just below the periosteal. Subperiosteal. Transosseous means through and through, from the oral cavity till the basal bone, we are putting an implant. Intramucosal, just below the mucosa or inside the mucosa. In the endorsal implant, we have a 3 type of implant. One is ramus frame. We have to make a long frame. Second is root form, and third is blade form, that is given by Linko. वो अभी हमने पीछे डिस्कस जो किया था. Then the endorsal implant, just read out, it is a type of various blade form, root form implants. It's root form basically we are using nowadays. It is designated to mimic the shape of the tooth, okay, but directional load and distribution. So it is most commonly used nowadays. Second is subperiosteal. Beneath the periosteum, overlying the bony cortex, do not penetrate into the jawbone. Consists of non-osseous integrated framework that rests on the surface of the jaw or beneath the mucoperiosteum, and can be bilateral or unilateral. Third, transosseous. The other name is the staple bone implant, mandibular staple implants, the transmandibular implant. That means from alveolar bone till the basal bone can put implant. Very similar to the nut and bolt arrangement. एक ऊपर लगाया, एक नीचे लगाया, पेट लगा के उसको टाइट कर दिया. used in mandible only and penetrate the entire jaw to emerge opposite the entry side, usually at the bottom of the chin. तो ऊपर बोल्ट है, नीचे एक टेप फॉर्म है, पूरा का पूरा इम्प्लांट करके उसको टाइट कर देते हैं. But these implants are not used nowadays. Intramucosal implant into the oral mucosa is used as the attachment site for the metal inserts. Then classification based on the attachment mechanism. Brain mark can be classified as a direct contact between the bone and the surface, and Charles Weiss is complete encapsulation of the implant with the soft tissue. Soft tissue interface could resemble highly vascular periodontal fibers of the natural dentition. So it is based on the fibro and the osseointegration. If there is a direct contact between the implant surface and the bone, it is called as osseointegration. If there is some fibrous tissue is formed in between the implant surface and the bone, then it is called as fibrosis. Then classification based on the macroscopic body design, slender form implant, threaded implant, then vacuum, perforated implant, the implant surfaces have some perforation, okay, then solid implant and the hollow implant. Then classification based on the surface again, the smooth surface, there is no thread, okay, it's completely smooth, then machine, then texture and coated implant. Coated implant means the implant surface is coated with some of the other substance. For example, with the PRF, okay, then the laser spray is also there, then some growth factors on the surface to increase the osseointegration. Then classification based on the type of implant material, metallic, ceramic coated, polymer and the carbon compound. But mostly we are using a titanium based implant or the metal based implant. But nowadays we are also introduced with the zirconia implants. Okay, but it is under the process. Most of the time we are using titanium based implant. Just touching the parts of dental implant. This is the implant. Okay, this is the endosseous type of implant. It is also called as fixture. Okay, then above this there is the abutment. The abutment is basically connect with the fixture and expose into the oral cavity, and it will, the crown is formed over the abutment, and this is the screw. This screw is basically connect the abutment with the fixture. So this is the basic component of the implant. This is again the implant, the screw, the abutment and the crown. The process of implant, you are going for the demonstration. First is the implant is inserted into the bone. So tomorrow we are discussing about the drilling protocol, how we drill, what is pilot drill, what is the sequential drilling system. According to that, we can make osteotomy first, and then we place the implant, suture it back, and then healing process of the bone, that is called as osseointegration for at least for 3 months. Okay, then after the 3 months, we take a radiograph. If the implant is osseointegrated, then we go for the second stage surgery. We just open the implant and put a gingival former for 1 week. So once the collar is formed around the implant, then we go for the abutment and the impression and crown fabrication. Okay, so these are the basic steps: implant insertion, healing, then second stage surgery and the crown. Again the same picture. First is the initial surgery. Second is the second stage, cover the screw, remove the osseointegration period, then abutment correction and take an impression and the final process. I just searched on the net and we find out accidentally the love was in the air. It is very famous for, है ना? हमेशा प्यार हवा में ही होता है. But you never put an implant in the air. If you are putting an implant in the air, patient will sue you. Okay? तो आज से हमें एक नया रूल बनाना है. देर रात तक फोन चलाना बंद. हम सब लोग रील्स देखते रहते हैं ना, because this is the first day of the implant module. So we stop taking the advantage of the phone and stop seeing the reels and the phone, and implant के लिए पढ़ना शुरू करना है. So if you are start reading the implant, start reading the books, then you definitely basically understanding about the topic, what is the basic implantology, and the most of the time we are reading 2 books. The first is the contemporary implant dentistry, that is given by the Mish, and second is by the Resnick. The Resnick is a very good book if you want to read at your level, because it will give the chapter according to the basic. First, the topic is the introduction, then what is the rationale, then the scope of the implant dentistry, what are the recent advancement, and according to that, this book is completely giving divide the topic. So these two books are very important for the implants. Thank you so much. Any questions?
Thank you, Dr. Amit. And I hope it was really informative to you all. I request Dr. Sumit Malhotra sir to continue further with this next topic, which is on osteointegration.
There is a 5 minute break. रहना यहीं पे, जाना नहीं कहीं पे, और फोन नहीं देखना, रील्स नहीं देखना, फोन फोटो करना एक बात करो.
सर अभी बोला गया था ना आपके
आजो दामा, आगे से रील बना ली. आजो आजो, पीछे नींद अच्छी आती है. आजो आगे आजो.
आजो मेरी आवाज वहां तक नहीं जाती है, आप लोग आगे आ जाओ प्लीज. साउंड कम ट्रैवल करता है.
आजो नहीं, आगे वाली रोज पे बैठ सकते हो आप लोग, फैकल्टी वाली रोज नहीं जाना. हेलो,
यहाँ आ सकते हैं. फर्स्ट रूमिंग खाली आइए, सब लोग आगे आइए. आइए, यहाँ पे कुछ लोग खाली रखते हैं, आगे आ जाओ. पीछे वाले आगे आ जाओ, इधर आ जाओ प्लीज.
आप लोग क्या लेते हैं? तुम लोग भी बैठे हो आगे. सारे एकदम सो गए. आजो आजो फटाफट जल्दी. ये 5 मिनट का ब्रेक इसीलिए.
खाली है आगे वाला. आ जाओ. 5 मिनट मेरे वेस्ट कर दिया आपने. एडमिशन लेने के बाद भी ये रो नहीं मिलती है। यू आर वेरी लकी कि इतने जल्दी आगे आ गए हो आप लोग। वो एक ही पीछे बैठे हैं, क्यों बैठे हैं सबसे पीछे? अभी भी यहाँ है हमारे पास स्पेस, लाइक तो हैव यू आगे। So okay, so Amit का lecture के बाद I think my job is very easy. I'm sure you know implantology by now. So this is a very difficult discipline. It's a very vast discipline, and these 2 days or whatever 4 days you have is going to be too short. It's going to be too short. All we can do probably is let you know what happens in implantology. Please, thank you. जितना आप अभी सीख लोगे, that's so you know when you start driving early, you become a better driver. When you start learning late like me, so you have to work very hard, and then still it's very difficult to compete with the young ones. I can never drive very fast. मैंने late सीखना शुरू किया, so you have an advantage, and I think that's a wonderful initiative the college has taken, so that they initiate you in this field of dentistry very early. किसी कॉलेज में इतनी बहुत कम कॉलेजेस में होता है, I think very few colleges can take that credit. So you already know what basic implantology is. One very important thing which already I think if you have friends who are practitioners, you would know. This is a revenue driving kind of a specialty. This will make sure that you do very well. If you do good implants, you will generate good revenue in it. If you go on doing traditional things, so it's going to be very difficult to do very well. Maybe Maruti या Hyundai ले पाएंगे, उससे ऊपर नहीं जा पाएंगे. So if you go to a Sarojini Nagar market, everybody is selling the same thing. If everybody is selling the same thing, where will you buy it from? You will go to the cheapest possible option. कि नहीं? So for you to generate more money, you have to do little more than what everybody else is doing. So for that means that you have to stay ahead of the curve. थोड़े दिनों में everybody will also start practicing implantology. ऐसा तो नहीं होने वाला है कि सिर्फ आप ही लोग सीख रहे हो, बाकी सब सो रहे हैं. This is not going to happen. So if you have to do it, then you have to do it very well. Again, you have to stand out in what you are doing. So we are going to just introduce this topic. Do you know what is osseointegration? I'm sure you do. So what is osseointegration? Okay, I'll come to that later. Who talked about osseointegration? Brain mark. So do you know उन्होंने अपनी BDS कहाँ से किया? He is a dentist, I suppose you know. So it will be very surprising for you to know he was not a dentist. He was doing his PhD in anatomy. और जब उन्होंने ये ढूंढा, when he found this process of osseointegration, this is not what he was looking for. He was trying to understand the capillary structures in tibia. एंड उन्होंने टाइटेनियम के कुछ छोटे छोटे प्लेट्स लिए, जिसके अंदर उन्होंने थोड़ा स्लाइड्स उन्होंने रैबिट के टीबिया में इंसर्ट किया. एंड ही वाज थिंकिंग दैट यू नो ही विल टेक आउट दैट स्लाइड आफ्टर सम टाइम एंड स्टडी इट अंडर द माइक्रोस्कोप. एंड देन ही रियलाइज्ड दैट इट वाज नियरली इम्पॉसिबल फॉर हिम टू टेक इट आउट. द स्लाइड्स व्हिच ही हैड मेड वर फ्रॉम टाइटेनियम एंड ही कुड नॉट टेक देम आउट. दैट इज व्हेन ही अंडरस्टूड द इंपॉर्टेंस ऑफ दिस discovery, and that is why this in a sense is a kind of serendipity. You know what is serendipity? You know that? Chance discovery. देखो number 3 पे क्या है? Even Coca-Cola which you use probably drink every day is also an accidental discovery. So great discoveries, super glue, great discoveries happen by chance. So now what is osseointegration? Basically, we are looking at a direct contact between the bone and the implant surface under light microscope. Light microscope पे जब हम observe करें तो हमें ऐसे लग रहा है that bone is directly in contact with the implant surface. That is the phenomenon of osseointegration. So how is it different from your tooth to bone contact? Tooth to bone contact में there is something which is there between the bone and the tooth surface, and that is the fibrous union, the periodontal ligament. Are you okay with having this between your implant surface and the bone? Why not? If it works there, then why not here? So before osseointegration came, at the same time there was a concept of fibro-osseous integration, and there were some studies which were talking about that. It should be similar to what we already have. Why should it be different? अलग क्यों होना चाहिए? And that was something called as fibro-osseous integration. Fail क्यों हुआ? Because we realized कि जब हम when we look at the tooth surface and the implant contact and the bone contact, we look at the periodontal ligament. The periodontal ligament is perpendicular to the bone surface and the tooth surface. उन दोनों के बीच में perpendicularly run करता है. So it can transmit the force. लेकिन अगर हमें interline fibrous tissue मिल रहा है between the implant surface and the bone, वो ना उसके parallel होता है, perpendicular नहीं होता. So it is not able to transmit any force. So what good is that kind of a union? That is why for your implant to be successful, you have to make sure that the bone grows on the implant surface. And there are various factors which will have an impact on this. If you are able to grow bone on the implant surface, you are a successful implantologist, a great dentist. If not, then you are a failed implantologist. So you have to, it is very important for us, and there are lots of studies which are going on what has an impact on this. If we can potentially change that environment and create an environment which allows us to form bone, कुछ भी करे bone बन रहा है, that is where the success lies. That is what we have to strive for. That is going to be our ultimate game. कुछ भी चीज जिससे कि वो नहीं बन रहा है, वो फेल हो जाएगा. वो हमें नहीं करना है. That's a learning curve. These concepts were introduced by Brainmark long back. He was doing these studies for a very long time, 1965 से, और उन्होंने कुछ concepts हमें बताए. So if you probably know about this, what is a one-stage implant and a two-stage implant? Anybody knows this? A one-stage and a two-stage implant. Nobody has an idea. So okay, so in the Brainmark concept, he said कि मैंने titanium का screw डाला. Now I have to allow the bone to form on that titanium screw. So that screw and the implant and the bone contact should be left undisturbed. So if you have anybody, किसी का fracture हुआ भी होगा, किसी ने friend को देखा होगा, family member को देखा होगा, when somebody has a fracture, they put both the fractured components साथ में रखते हैं, and they make sure that वो fixate हो जाए, हिले नहीं, immobilize करते हैं ना, immobilization एक बहुत important concept है ना, उस एरिया को प्रोटेक्ट करते हैं. अगर वो एरिया प्रोटेक्टेड नहीं होगा तो हमें ऐसा लगता है कि वो हीलिंग खराब होगी, obviously. So this concept in Brainmark's times was that if you put an implant, उसको पूरा कवर कर दो soft tissue, bone से. Allow it good time to heal. So bone is a slow healing tissue. It takes time to heal. Slow growing tissue. That's why you see union में कम से कम 6 हफ्ते और इतना लंबा रेस्ट देते हैं. क्यों देते हैं? Because bone slowly grow करता है. तो हमें कुछ टाइम देना पड़ेगा. तो at Brainmark's concept 6 months का टाइम देते हैं. 6 months के लिए इम्प्लांट डाल के छोड़ देते थे. उसके बाद में उसको ओपन कर देते. पर आज की जनरेशन जो है ना रेस्टलेस है. उनको इतना टाइम कौन वेट करेगा? Your patient will also not wait. Will they wait? So if you are charging say 50,000 or 30,000 or whatever amount, X amount for an implant, and you tell the patient कि आपको 6 months के बाद लगेगी, पैसे अभी दे दो, तो क्या देगा आपको? So obviously वो कहेगा थोड़ा जल्दी चाहिए. If he or she loses a front tooth, would they be willing to wait for 6 months? So now we have to find ways कि मेरी healing faster हो. Yeah. So then for that to happen, we have to understand how healing happens. ये एक बहुत अमेजिंग स्टडी है अब्राहमसन की. इन्होंने क्या किया? इन्होंने एक स्टडी किया. उसके अंदर अगर आपने ध्यान से देखा हो, इम्प्लांट के डिजाइन ज्यादातर थ्रेड होते. फ्लैट इम्प्लांट्स देखे कभी? क्यों नहीं देखे? वो मैं बताऊंगा आगे क्यों नहीं होते हैं. पर ये थ्रेडेड डिजाइन होता है. अब ये थ्रेड के दो जो एलिवेटेड पोर्शंस हैं थ्रेड के, उनका जो डिस्टेंस है उसको क्या बोलते हैं? पिच, पिच बोलते हैं। तो अगर मैं बोन के अंदर इस इम्प्लांट को स्क्रू करूंगा तो जो एलिवेटेड पोर्शन है वो बोन से एंगेज कर जाएगा, बीच वाले एरिया में क्या होगा? ये गैप बनेगा। वो गैप को उन्होंने बोला है वूंड चेंबर, उन्होंने बोला एक चेंबर बन रहा है जहां स्पेस आ रहा है। So, क्या हम आर वी एब्सोल्युटली हैप्पी कि मेरा कॉन्टैक्ट सिर्फ वो टिप टिप पे आ जाए, और आई वांट दैट कॉन्टैक्ट टू बी एवरीवेयर? For that to happen, I need some bone to form in that wound chamber. So they studied this for a very long time. So normally healing में क्या होता है? अगर ऐसा होगा एक गैप बनेगा तो गैप के अंदर क्या फिल होगा? सबसे पहले क्या फिल होगा? ब्लड फिल होगा। अब ब्लड क्यों इंपॉर्टेंट है? ब्लड क्यों इंपॉर्टेंट है हमारे लिए हीलिंग के लिए? ब्लड क्या देता है हीलिंग के लिए हमें? सब कुछ देता है एक्चुअली। ब्लड में कुछ सेल्स हैं, देयर आर लॉट्स ऑफ सेल्स इन ब्लड. व्हिच वंस? Platelets are there, yes. There are some WBCs also. So what will you think will be the role of WBCs here in healing? WBCs में सबसे पहले फास्ट सेल कौन से आते हैं वहां पे? न्यूट्रोफिल्स. न्यूट्रोफिल्स क्या करेंगे वहां आके? क्यों इंपॉर्टेंट है हमारे लिए? न्यूट्रोफिल्स बैक्टीरियल इन्फेक्शन के लिए तो लड़ाई करते रहते हैं. Yes, that is one thing we want to avoid infection. Do they have any other role? So say if you are drilling a hole in the bone, you are causing some dead cells to be there. वो dead cells वहां से हटेंगे कैसे? फाइगोसाइटोसिस होगा, कुछ पहले माइक्रोफाइगोसाइट्स आएंगे, माइक्रोफाइगोसाइट न्यूट्रोफिल्स होते हैं, फिर वो सिग्नल देंगे for other cells to come which are bigger phagocytes, which you said are macrophages. They will come there, slowly they will clear all that area. एक वहां पे ब्लड के अंदर धीरे धीरे करके क्लॉट बन के फाइब्रस यूनियन होगा. यूनियन होने के बाद में धीरे धीरे कैल्सिफिकेशन स्टार्ट होगा. So this is what happened, a series of events. First they saw coagulum formation, then slowly some granulation tissue started forming. Then there was a provisional matrix formation, then oval bone, then there is parallel fiber orientation and lamellar bone. I'm sure you are not interested in this. है ना? किसी को भी इसमें तो कोई इंटरेस्ट नहीं है, तो ये क्यों पढ़ना पड़ता है हमें? क्यों पढ़ना पड़ता है? इसमें स्ट्रॉन्गेस्ट बोन कौन सा होगा? लैमेलर बोन. आप कब अपने इम्प्लांट को लोड करना चाहोगे? जब सफिशिएंट स्ट्रेंथ आ जाए, जिससे कि मेरा जो बॉन्ड है, वो जो बॉन्ड बना है वो ब्रेक ना हो. ये इंपॉर्टेंट है ना मेरे ऑस्टियो इंटीग्रेशन के लिए, ऑस्टियो इंटीग्रेशन के लिए. So we have to know at what point is my bond the strongest or strong enough to take the load of the occlusal forces. ये हमें समझना पड़ेगा ना, इसलिए ये स्टडी बहुत इंपॉर्टेंट है. और बहुत सारे फैक्टर्स इसमें. एक चीज और हमें समझनी है, बोन एक कंटिन्यूअसली रीमॉडलिंग टिश्यू. तो समझ लो मेरा एक इम्प्लांट सरफेस है, मैंने ऊपर बोन बना दिया. So do you think the bone will stay, that same bone will stay there forever? Bone is a remodeling tissue. So you want some amount of resorption will go on happening. So you want continuous new bone formation in that area for that osseointegration to sustain. हमेशा बोन बनते रहना चाहिए, जितना लॉस हो रहा है उससे ज्यादा, तभी मेरी osseointegration सस्टेन कर पाएगी. Initially तो मैं टाइट करके डालता हूँ, I make a smaller hole and put a wider implant. उस टाइम तो osseointegration चाहिए ही नहीं मेरे को ना, वहां तो होता ही नहीं कुछ osseointegration. वहां तो मैंने क्या किया, सिर्फ फिक्सेशन किया है. उसके बाद बोन की रीमॉडलिंग हो रही है. मैं देख रहा हूँ बोन स्लोली बन रहा है, then that is maturing. At one time it becomes strong enough. You start loading it. When you load it, some amount of cell death will happen. Then there has to be more formation of bone at all times, जिससे कि मेरा osseointegration सस्टेन रहे, मेरा ये लॉन्ग टर्म सॉल्यूशन रहे, शॉर्ट टर्म नहीं, 6 months या 1 year या 2 years नहीं. We are looking at multiple tens of years. तभी हमारा काम चलेगा ना. तो इसके लिए अब होने के लिए your body, your blood should be healthy. If you have an unhealthy patient and a healthy patient, so if a patient जिसके अंदर say न्यूट्रोफिलिक डिफेक्ट है, इतना स्ट्रॉन्ग नहीं है, और एक पेशेंट जिसमें अमेजिंग बोन, अमेजिंग कैपेसिटी है, यंग पेशेंट वेरी हेल्दी, इसमें दोनों में इम्प्लांट का सेम सक्सेस कर गया. So a very important parameter for you to understand it. The patient is also very important and a key factor in deciding whether your implant will succeed or not. So we have some clear-cut omission जिसमें हम कहते हैं कि इन पेशेंट्स का हम नहीं करेंगे या इनका एक हायर चांस है फेलियर का. फॉर एग्जाम्पल एक स्मोकर में हमें पता है कि न्यूट्रोफिल एक्टिविटी रिड्यूस हो जाती है. The chemotaxis of the neutrophil reduces. The neutrophils take longer time to react. And they are not as strong as in a non-smoker. So the smoker carries a higher risk. Even if, say for example, you got an implant done when you were 20, you started smoking at 25. Will it not have an impact? Will it have an impact on osseointegration? तो पहले हो गया था. When you were 20 and you were not smoking, osseointegration तो हो गया था. At 25 smoking start किया तो क्या फर्क पड़ जाएगा? फर्क पड़ेगा रीमॉडलिंग पे. रीमॉडलिंग पे पड़ेगा इन ओवर अ पीरियड ऑफ टाइम. दैट osseointegration will not be as strong as required. So we now know that there are various steps which happen. We won't be covering this in detail because you are not interested, you are sleepy already. We know that there will be initially a formation of unorganized bone, which is called a movable bone, and slowly it organizes better. It gets shaped into those lamellae. It gets shaped into that lamellae, and then it becomes stronger. So what we generally see is, sir, by 4 weeks we start seeing some amount of lamellar bone happening. ठीक है? So अब important चीज क्या है कि शुरू में मैंने क्या किया था? Fixation. फिर मैंने देखा some amount of bone resorption started happening. So in the initial 4 weeks, my contact between the implant and the bone surface will become stronger or weaker? No, it will become weaker because there is resorption happening. Proper bone formation will take some time, more than 4 to 6 weeks. So अगर तो मेरे को लोड करना है उस इम्प्लांट को, अगर मुझे बहुत अच्छा फिक्सेशन मिल गया, तो या तो स्ट्रॉन्गेस्ट मैं करूँ शुरू में या फिर 6 वीक्स के बाद. बीच में मैं उस इम्प्लांट को टच नहीं करूं. उस टाइम पे मेरा यूनियन जितना पहले था उससे लेस स्ट्रॉन्ग हो गया. ओके, सो नाउ व्हाट इज द सिग्निफिकेंस? ये हिस्टोलॉजिक स्टडी है, आपको कोई इंटरेस्ट नहीं है आई एम श्योर, बट व्हाट इज द सिग्निफिकेंस ऑफ दिस इज दैट इफ आई प्लेस एन इम्प्लांट आई कैन मेक अ प्रोस्थेसिस underloaded either at the same time. If not, then I can't place the prosthesis for 6 weeks. So then is 6 weeks to 2 months. इतना टाइम मुझे रुकना पड़ेगा. ओके, अब ब्रेन मार्क के टाइम पे क्या था? 6 months. अब हम कहाँ पे आए हैं? 2 months, 6 weeks पे. तो ये क्यों आए होंगे? क्योंकि हमने काफी अंडरस्टैंडिंग डेवलप किया बियॉन्ड ब्रेन मार्क. We understood that we can change certain things in the implant. We can modify the surface of the implant. We can modify the biomechanics of the implant. We can look at the implant contacts, the implant to abutment contact. These things, if we do better, the healing can be little faster. That was the goal. The goal was to give a faster solution to the patient. Because we are not as patient as people were there in 1965, जो कि 6 महीने रुक जाते हैं. Now, if you don't give a prosthesis immediately, you'll go to the next door dentist. So that is why you have to be faster, you have to be better, you have to be more reliable, you have to be giving a more predictable kind of a solution. For this, you have to understand certain basics of histology. So now we already know पहले blood बनेगा, वो blood clot होगा, एक visual matrix बनेगा, procallus बनेगा, फिर वो matrix organize होगी, धीरे-धीरे करके lamellar bone बनेगा, and the strength will increase, and when there is a sufficient strength, only then you can load the implant under occlusion. So you might have heard of immediately loaded implants. So there are two things. Normally क्या होता है? एक immediately placed implant और एक immediately loaded implant. ये अलग-अलग चीजें हैं. Do you understand this? So आई एम श्योर मोस्ट ऑफ यू डोंट, इट टेक्स अ लिटिल टाइम। अगर मैंने आपके पास एक पेशेंट आया जिसका एक्सट्रैक्शन 2 साल पहले हुआ था, 2 साल पहले हुआ था, वो सॉकेट पूरा हील हो गया एंड यू प्लेस एन इम्प्लांट, ओके, इट वाज अ वेल हील्ड सॉकेट। एंड लुक एट अनदर सिचुएशन कि एक पेशेंट आया, उसका क्राउन फ्रैक्चर हो गया एंड ही वांट्स अ रिप्लेसमेंट, यू टेक आउट द रूट एंड प्लेस एन इमीडिएट इम्प्लांट एट द सेम टाइम। These situations are different. One was a well-healed socket, the other is a place जिसमें root छोड़ी थी and you have made a narrower implant, so there is some gap. So this is called an immediately placed implant. Okay? In both these things, I can do two things. I can submerge both the implants, और अगर मेरे को अच्छा वो मिल गया osseointegration, a good feeling, the patient is healthy, and anterior implant जिसका occlusal load नहीं आने वाला है, तो I can make a provisional prosthesis, provisional, I'll make sure कि उसका occlusal contact नहीं आए, that is an immediately loaded implant. So immediately placed is when you place it at the time of extraction, immediately loaded is when you give a prosthesis at the time of insertion. Difference समझ में आया कि फिर से चाहिए किसी को, फिर से चाहिए? दो केसेस हैं, मैंने रूट निकाली और इम्प्लांट डाल दिया, ये हो गया इमीडिएटली प्लेस्ड इम्प्लांट, हाँ? और एक केस है कि मैंने जब इम्प्लांट डाला तभी क्राउन लगा दिया, दैट इज एन इमीडिएटली लोडेड इम्प्लांट। टू डिफरेंट थिंग्स ना ऑल टुगेदर। So you have to understand when we talk about immediate implants, generally we talk about immediately placed implants. Immediate implant means immediately placed implant. Loading के अलग-अलग प्रोटोकॉल होते हैं depending on a lot of factors, huge amount of factors. Generally, prosthodontists, or as we are evolving in our understanding of prosthodontics, we are trying to do, what are we trying to do? Reduce the time duration. So we want to give an immediately placed and immediately loaded implant. सबसे कम टाइम तो उसी में लगेगा ना, अभी इम्प्लांट डाला अभी लोड भी कर दिया। इसके लिए तो आया ना पेशेंट, इसको जगह इमीडिएटली सो भी गया ना, इमीडिएटली स्लीपिंग। So temporary, provisional crown, I say. Provisional is always a temporary crown. Why? Because मैंने अभी उसको prosthetically load तो किया ही ना, prosthetically shy रखा। Full occlusal loading नहीं दे रहा, strong नहीं है connection। तो prosthetically I kept a little distance. I kept a little shy of the occlusal forces. But that is also not a very easy thing to do. आपको लग रहा है occlusal forces होते हैं क्या? Tongue के, cheek के, all those forces are also there. That is why last time he was completely covering it. Now we are understanding, we are more confident. That is why in certain cases, for example, a lateral incisor comes to you and you place a provisional crown and occlusally अंदर से उसको पूरा का पूरा ट्रिम कर दो, तो occlusal loading नहीं आएगी ना। अगर आपके पास good amount of bone है, good quality of bone है, then you can do it. Even if it's a molar, say a mandibular molar, and you have got a very wide implant, a long implant, the patient is young, the bone is very good, you can place a crown, लेकिन वो occlusal level से short होगा, उसमें ना तो compressive force आएंगे, ना eccentric forces आएंगे, ना centric ना eccentric, ये हमें करना पड़ेगा। इसका advantage क्या है? अगर मैं 2 बार नहीं करता तो मुझे 2 बार सर्जरी करनी पड़ती। पहले मैंने सबमर्ज किया, फिर उसको सर्जिकली फिर से एक्सपोज करके कुछ और लगाया, उसको हील होने दिया, फिर ऊपर से एक क्राउन लगा, तो दैट इंक्रीजेस माय टाइम ड्यूरेशन एंड इंक्रीजेस द सर्जिकल टाइम, माय पेशेंट टाइम, माय एक्सपेंसेस, ऑल दीस आर इंक्रीज। सो इफ आई कैन रिड्यूस इट एंड डू इट इन अ रिप्रोड्यूसिबल प्रेडिक्टेबल वे, दैट विल बी द बेस्ट थिंग टू डू। समझ आ रहा है? कुछ चीजें हम स्किप करते जाएंगे जैसे जैसे लगेगा। अब हमें इतना समझ में आ गया, शुरू में इन्फ्लेमेशन होती है, फिर धीरे धीरे प्रोलिफरेशन होती है, बाद में मैचुरेशन होती है, ठीक है, ये तो समझ में आ गया। अब अलग अलग टाइम्स दिख रहे हैं, मैचुरेशन में कम से कम 28 डेज लगते हैं, तो नॉर्मली 1 मंथ तक हम लोड नहीं करते, 1.5 मंथ्स के बाद देखते हैं अगर हमें अच्छा इंजरी मिल रहा है तभी लोड करते हैं, उससे पहले लोड कभी नहीं करेंगे। तो शुरू का अलग अलग नाम है। द फर्स्ट स्टेज इज कॉल्ड एन ऑस्टियोफिलिक स्टेज, अगेन The same stage, osteoconductive when movement bone is formed, and osteoadaptive when there is remodeling and mature bone is forming. That is when you think of loading an implant. Let's forget this. Now, this concept. So most of these are theoretical concepts, and that's why some of you are sleeping to it. But if you sleep now, you will have to pay some more money to learn this again. ये important चीज है. अब ये क्या होता है? Distant osteogenesis और contact osteogenesis. अब मैंने आपको दो सिचुएशन बताए थे. एक एक्सट्रैक्शन हुआ 2 years पहले, एक हुआ immediate extraction. So when I am doing an implant in a patient जिसकी 2 साल पहले एक्सट्रैक्शन हुई थी, तो उसमें मैं होल बनाऊंगा, होल को ड्रिल करूंगा, सेम है 3 mm का, तो इम्प्लांट डालूंगा 3.5 mm का, थोड़ा सा बड़ा इम्प्लांट डालूंगा वाइड. सो अगर मैंने एक राउंड होल बनाया, राउंड इम्प्लांट डाला, तो एट मोस्ट प्लेसेस मेरे इम्प्लांट और बोन के बीच में ज्यादा डिस्टेंस नहीं होगा. इम्प्लांट एंड द बोन मोस्टली अबटिंग होंगे, बोन विल फॉर्म ऑन द इम्प्लांट, दैट विल बी कॉन्टैक्ट ऑस्टियोजेनेसिस. डिस्टेंस है ही, तो सीधा ऑस्टियोब्लास्ट इम्प्लांट सरफेस के ऊपर फॉर्म होना शुरू हो जाएगी. ओके, वेरी ग्रेट सिचुएशन. पर अगर मैंने से एग्जांपल एक मैंडिबुलर मोलर निकाला, और मैंडिबुलर मोलर 10 mm 3 रूट्स थे, हाँ 10 mm का मीजियो डिस्टल गैप था, इम्प्लांट डाला मैंने 5 mm का, दोनों साइड पे इम्प्लांट के बोन नहीं है, कहीं कहीं नहीं है, कहीं कहीं पे कॉन्टैक्ट आया, कहीं कहीं पे नहीं है. ऊपर से क्राउन वाइड होता है, रूट वाइड होती है, नीचे से नैरो होती है, नीचे एंगेज कर दिया, ऊपर गैप आ रहा है. अब इतना बड़ा गैप आ रहा है, तो वहां बोन कैसे बनेगा? बोन तो बहुत दूर है, बोन कैसे बनता है? इसीलिए कह रहा था आगे आ जाओ, पीछे नींद ज्यादा आती है. सो ओके, इसको थोड़ा चेंज करते हैं. अगर आपके यहाँ से किसी ने स्किन निकाल दिया, हाँ नेल मार के स्किन निकाल दिया, अभी स्किन का जो नए सेल्स बनेंगे वो कहां से आएंगे? ब्लड में से एपिथेलियम आए. एपिथेलियम कहां से आएगा? एपिथेलियम सेल आपने निकाल दिए. फिर से जोर से बोलो, मेरे को सुनाई नहीं देता है. पेरिफेरी, कौन बोला ये? वेरी गुड. सो पेरिफेरी से सेल्स रोल होके वो गैप को फिल करते हैं. तो साइड से वुंड फिल होता है और सेंटर में एंड में जाके फिल होता है. ये एपिथेलियम का है. ऐसे ही कोई भी सेल धीरे धीरे आगे बढ़ेगा ना, सीधा जंप मार के थोड़ी चला जाएगा. पर हमने ये देखा कि अगर वो डिस्टेंस 2 mm से कम है, if it is less than 2 mm, then osteoblast can still jump that gap through that provisional matrix जो बनी थी, उसके थ्रू वो सीधा बोन जो है इम्प्लांट सरफेस के ऊपर बना सकते हैं. That is called as distance osteogenesis. कब कितना बताया मैंने? गैप approximately 2 mm गैप. अगर उससे ज्यादा गैप है तो आप उसको छोड़ नहीं सकते, फिर आपको बीच में कोई बोन सब्स्टिट्यूट डालना पड़ेगा. This gap is called as, nobody knows, the jumping gap. जंपिंग डिस्टेंस और जंपिंग गैप कितना होना चाहिए? लेस देन 2 mm. अगर ज्यादा होगा तो अब क्या करेंगे? ग्राफ्टिंग करेंगे. ठीक है, इंपॉर्टेंट कंसेप्ट है. सो नाउ व्हाट कैन इन्फ्लुएंस योर osseointegration? अब there are a lot of people, obviously this question looks like a joke, but it is very important. If you ever have to, if you pass your PDS and you कोर्स आपने कर लिया है, बेसिक कोर्स, इसके बाद में जब आप अपनी क्लिनिकल प्रैक्टिस खोलेंगे तो अपना फर्स्ट इम्प्लांट चूज कैसे करेंगे? कैसे करेंगे? थोड़ा सा नॉलेज होगा आपको, थोड़ा बहुत आपने कोर्स में सीखा होगा, पर आप ये डिसीजन लोगे कैसे कि कौन सा इम्प्लांट लेना है? सो मोस्ट पीपल कैसे लेते हैं? मोस्ट पीपल सबसे पहले देखते हैं किट नहीं है, कौन किट दे देगा, कौन से इम्प्लांट कंपनी, सस्ता कौन सा पड़ेगा. सीनियर से पूछ लेते हैं आप कौन सा यूज कर रहे हो, है ना, कौन से इम्प्लांट वाले का नंबर मेरे पास है, सर्विस कौन दे देगा, अगर फेल हो गया तो रिप्लेस कौन कर देगा. यही चीजें डिसाइड करते हैं ना. तो इसका मतलब क्या हुआ कि हमारी नजर में मोस्ट ऑफ द इम्प्लांट्स आर सिमिलर. इफ दैट वाज द केस तो फिर हम अभी तक ब्रेन मार्क वाला ही कर रहे होते. सो देयर आर अ लॉट ऑफ फैक्टर्स इन इम्प्लांट डिजाइन which have an impact on the implant success. So in the beginning, we were talking about, when we were talking about Abramson's दैट्स एक्सपेरिमेंट। उस एक्सपेरिमेंट में हमने बोला कि योर वुंड हीलिंग कैपेसिटी शुड बी वेरी गुड। So if you have a young patient who is very healthy and who has adequate amount of bone and the bone quality is also very good, then the implant design might have a lesser impact on the rate of implant success. But in more complicated cases, when the bone is not enough in volume or in quantity or in the quality भी अच्छी नहीं है या patient कहीं से compromised है, then your implant success will depend to a large degree on the implant design. So you have to understand some key components of implant design. First is material. किस चीज से बनता है? टाइटेनियम। कभी किसी ने देखा है किस चीज से बनता है इम्प्लांट मटेरियल? टाइटेनियम के बहुत सारे ग्रेड्स आते हैं। कोई ग्रेड 4 कह रहा है, कोई ग्रेड कह रहा है, कोई कमर्शियली प्योर टाइटेनियम बोलता है, कोई ग्रेड 23 बोल रहा है। So you have to understand. Maybe in the next 45 minutes में पूरा आपको नहीं समझा पाऊंगा, but do you understand now that there are three various kinds of materials? All of them will give you certain advantages and certain disadvantages. The cheaper implants will be cheaper for a reason. They will be cheaper for a reason. Obviously, the more expensive implants, if people are buying it, there must be some reason. So you have to understand that reason, not just by जो आपको बोल रहा है, जो बेच रहा है बोल रहा है बेस्ट इम्प्लांट है, कौन बोलता है कि मेरा अच्छा नहीं है, सभी अच्छा ही बोलते हैं ना। So all of these things will have an impact. There are various grades, as I said, grade 4 and grade 5 ज्यादातर कंपनीज बेचती हैं। वेरी स्ट्रॉन्ग ग्रेड इज ग्रेड 23। ज्यादातर जो हिप अभी जो ऑस्टियो इंटीग्रेशन का कंसेप्ट है, ये सिर्फ डेंटल में यूज नहीं हो रहा है ना। वेयर एल्स डू यू थिंक इट इज यूज्ड? Orthopedics has a huge application, so they have a lot of knee joint replacements and hip joint replacement. Those are extremely weight-bearing joints. They have an impact on the quality of life of the patient. There they don't take any risk. There are a lot of implants which you see are grade 23 titanium implants. In dentistry, most of them are grade 4 and grade 5. Grade 4 is a little easier to process. So all the cheaper implants will also mostly be grade 4 implants. They are decently good. Now I was, whenever I have a habit, मेरा lecture होता है मुझे बहुत stress होता है, so I was driving from Noida, तो मैं पूरे टाइम पे I was listening to somebody on YouTube. He was a guy जिसके पास 3 engineering degree थी, and he was also a professor in prosthodontics in one of the colleges in US. He was talking about a concept of cyclic fatigue. वो क्या बोल रहा कि all these implants, there were 4 implants that tested, एक study थी, उसमें 5,000 बार, 5 लाख बार एक चीज को बार बार इम्पैक्ट किया, 5 लाख टाइम्स। आफ्टर दैट 2 implants failed, fractured, cyclic fatigue बोलते हैं, मल्टीपल यूज करके टूट गए। अब ये 5 लाख कितना बड़ा होता है in terms of oral cavity? How many times do we contact our teeth? Multiple times, probably in a minute you will do that 2-3 times. So over a day, then over some years. So all these cheaper implants, they tend to have a higher cyclic fatigue. So they will fracture or snap under certain situations, not every time. अगर आपने amazingly implant place किया, अच्छा mild contact है, तो कोई प्रॉब्लम नहीं है, लेकिन अगर वो ब्रक्स है फिर that situation will lead to higher stresses and higher cyclic fatigue. So will you be able to take this risk of placing an implant which has a higher cyclic fatigue? No. So that is why choosing the right implant system is important. So if your patient has a higher force, then you probably will have to go for a higher quality of an implant, a grade 23 or a grade 5 implant. Are you there with me? So this, do you think, is an important thing when you decide on a implant? Now, क्या आप सब सिस्टम हर एक के लिए सूटेबल होंगे? Obviously नहीं, एक ब्रक्सर एक नॉन ब्रक्सर की नीड अलग है। Obviously, so you will have to understand this when you are choosing the right implant. Now, a very important concept, जो forces लग रहे हैं हमारे, उसमें 3 तरह के forces हैं: shear, compressive और tensile. So again, through the same lecture, compressive का मतलब क्या है? Bone likes to be hugged. बोन को ऐसा लगता है इसको दबाने वाला जो होता है ना प्रेशर कंप्रेसिव फोर्स, उसके लिए अमेजिंग है. In that case, it grows. There is good amount of remodeling happening. Bone hates this shear stress. जो ये implant के surface और bone surface के perpendicular जा रहा है, ये worst kind of stress है. इसमें सबसे ज्यादा bone को नुकसान होता है. Okay? और बीच में कहीं आता है tensile. So we have to have an implant design which reduces shear forces, which increases compressive forces. ये समझ में आया सबको? So perpendicular bone को दबाने वाला force उसके लिए best है, stimulatory है, और worst है जो उसके perpendicular surface पे जा रहा है. Okay? अब वो क्वेश्चन मैंने आपसे पूछा था, थ्रेडेड डिजाइन हम क्यों लेते हैं? ज्यादातर जब मैं ये क्वेश्चन पूछता हूँ सब क्या देते हैं आंसर कि it increases the surface area. Wrong. It's not wrong. But more importantly, if you have the right kind of thread design, you increase compressive stresses and reduce shear stresses. If you have a flat surface, all the force is perpendicular to the implant surface. That's a shear force. That is not good for the implant surface. So what do we want then? What do we want? So let's look at this. इस पिक्चर को छोड़ के थोड़ी सी डिफिकल्ट होगी, या ये समझ में आ जाएगा आपको? Let's look at this. ये एक थ्रेड है, ये ब्लैक वाला सरफेस जो है ये इम्प्लांट सरफेस है. हाँ, ये बोन है, फोर्स आ रहा है ऊपर से. जब ये फोर्स लग रहा है तो यहाँ पर क्या कौन सा फोर्स आएगा? कंप्रेसिव की शियर. देखो बेटा इसके परपेंडिकुलर है ना फोर्स सरफेस के, यहाँ कंप्रेसिव आया. तो दिस काइंड ऑफ डिजाइन इज अ square kind of a design which helps more compressive forces. So if you understand biomechanics, there is some amount of compressive force being happening here. इस केस के अंदर यहाँ पर shear आ रहा है, पर यहाँ compressive आ रहा है. ऐसे ही pure compression हमें कभी नहीं मिल पाता, but we have to increase the chances of getting some compression. So our design should promote compressive forces. For that, the best designs are square threads and something called a reverse buttress. Let me show you the thing. ये तीन डिजाइन है, ओके? एक V shape thread. V shape thread क्यों बनाए? हमें लगता था कि वो ना छोटा हमने ऑस्टियोटॉमी बनाया था and we placed a wider implant, so वो easily screw हो जाएगा. This is easy to screw, V shape, but it has the least amount of compressive forces. There are a lot of tensile and shear forces happening here. A square thread, the thread इतना मोटा सा है तो वो जल्दी से स्क्रू नहीं होगा. उसके लिए आपको बोन को प्रिपेयर करना पड़ेगा. उसको हम टैपिंग बोलते हैं. टैपिंग बहुत डिफिकल्ट होता है, but that will have a good amount of compressive forces. And the best is this is a buttress kind of a thread. This is not a good design. This is something like जैसा आपका nail होता है. अब nail अगर आप ध्यान से देखेंगे, let me show you one more picture. Look at this design, which is more like a nail. Nail normally अगर ये ऊपर है, टॉप है, ये हमें फोर्स वहां से आ रहा है, तो nail ऐसा होता है. This is a buttress kind of a design. पर इसके अंदर आप देखो फोर्स यहाँ आ रहा है, लेकिन यहाँ पर टेंसाइल हो जाता है. इसको जब हमने उल्टा किया, तो यहाँ पर कंप्रेसिव फोर्स आने लगा. This is called a reverse buttress kind of a design. This is a wonderful design again. So a reverse buttress is a very good design. A square thread is a good design. A lot of companies do different designs. It is not that कि वो successful नहीं हो रहे, but there is a higher chance of success if you understand the design of a thread. So what is a pitch? We said pitch का distance होता है. उससे क्या फर्क पड़ेगा? अगर pitch कम है, अगर मैंने दोनों thread पास कर दिए, दूर करे, उससे क्या फर्क पड़ेगा? Surface area बढ़ेगा ना, इंटीग्रेशन बेटर होगी. अब उसकी एक डेप्थ भी है, कितना डीप है, उससे क्या फर्क पड़ेगा? हाँ, ये शैलो है या डीप है थ्रेड, उससे क्या फर्क पड़ेगा? जितना थोड़ा सा वाइड होगा उतना फास्ट एंगेजिंग होगा. So people who are surgeons mostly, they prefer these kind of design which engage bone very well. So they give you a very good feel So the primary stability, which primary stability का मतलब होता है जो हमें पहले मिली, और secondary stability आता है जब वो osseointegration के बाद मिली. So this gives you the deeper threads, the sharper threads give you good primary stability, which you would like to know early. Square threads will give you little less primary stability, but they are good with compressive forces, so they give you good secondary stability. So you have to understand what is required in your patient and then decide on what kind of an implant design will you take. So there can be parallel implants and there can be tapered implants. Nowadays, most of the implants have tapered structure, again because that also encourages some amount of compressive force. थोड़ा compression ज़्यादा पड़ता है, इसलिए we use tapered kind of threads, implant designs. Now you want, अब आपने एक implant डाला, you don't want the implant to rotate, so in the apex you give some design element. This is the anti-rotation. We call that an anti-rotational element. That can be one flat surface, that can be a small hole in the end. Any such thing, that is a design characteristic, varies from implant to implant. That is called as anti-rotational feature. Now important चीज जब सो रहे हैं उठ जाएं, फर्स्ट उठा दो यार सबको, उठ जाओ थोड़ा, important चीजों पे आ रहे हैं हम. नहीं हम लेकिन sleep better. So now important thing, implant width और implant length, इसका क्या impact पड़ता होगा? So if you have a wider implant or a narrower implant, आप confident किसमें होगे? Wide implant में, क्यों? Where will you be more confident? So if you have a bone, say 10 mm का bone है, width में, उसमें आपके पास choice है 6 mm डाल लो, 7 mm डाल लो, 8 mm डाल लो, 5 mm डाल लो, आप कहाँ confident होंगे? 8 mm पे confident, कोई 9 mm भी होगा फिर? कुछ रीजन होता होगा ना, नंबर्स तो चलो नंबर है, तो ऐसे ही अभी तो किसी को भी नहीं पता क्या है बोल रहे हैं. पर obviously we want bone to be on all sides, that is essential. तो मैं 8 में तो नहीं जाऊंगा, क्योंकि अगर 8 में चला गया तो बोन बचा ही नहीं साइड में, एक mm बच गया, तो 8 में नहीं जाऊंगा. पर अगर 2-2 mm बच गया और 6 mm डाल दूं, या 3-3 mm छोड़ के 4 mm डाल दूं, तो मैं सोचता हूँ कि एक वाइडर इम्प्लांट होगा तो उसका सरफेस एरिया बड़ा होगा. जितना सरफेस एरिया बड़ा होगा उतना बोन टू इम्प्लांट कॉन्टैक्ट बड़ा होगा, और उतना मेरा फोर्स डिस्ट्रीब्यूशन बेटर होगा. That is why as wide as implant as possible, understanding that there should be sufficient bone on the sides. One important thing. Also important है aesthetics. अगर एक anterior area में बहुत wide implant डालूंगा तो it will look unaesthetic. So posterior में I would like to place a wider implant. Anterior में I can go do this naturally a narrower implant. अब अगर मैं implant wide नहीं डालता हूँ तो long डाल देना. मतलब अगर मैं आपको चॉइस दूं कि 4 mm का 4 mm विड्थ का डायमीटर का 10 mm का इम्प्लांट डाल दो, या 3 mm का 15 mm डाल दो. 3 mm पसंद नहीं है, इसको नहीं है. नहीं वो तो हम सेव करके चलेंगे, सीबीडीटी में देखेंगे नाम नहीं है. कंप्रेस तो बेटर है. नहीं क्यों फ्रैक्चर होगा? हमने डाला वाइड था ना इम्प्लांट, बोन तो बहुत वाइड था, हमने तो नैरो सा इम्प्लांट डाला, और कहाँ फ्रैक्चर होगा? क्यों फ्रैक्चर होगा? पर हमने ओके, सो दिस इज बोथ दीज थिंग्स, increasing the length and increasing the width, they increase the surface area, isn't it? Both of them will increase the surface area, but there have been a lot of studies which say that जो maximum force का distribution होता है, we do something called a finite element study. This is a non-clinical kind of a study in which you simulate the same thing in a model, in an AI-based model. In that we see that the most of the stress concentration happens in the coronal one-third of the implant. So longer implant will not have that good an impact. A wider implant will be probably better, because force distribution सारा उस wide area में हो गया जो ऊपर के 3-4 mm के अंदर था. So if given a choice, always place as wide an implant as possible, while understanding that there should be good amount of bone around the implant. Okay? So minimum अगर हम डालते हैं depending from implant to implant, we would like to have more than 4.5 or 4.2 mm of implant diameter in a posterior area. Minimum 4.25 से कम हम normally नहीं डालते. Wider 5 mm, 4.5 mm डालना प्रेफर करते हैं. Anterior implant में हम 3.5 भी डाल देते हैं. और sometimes mandibular के अंदर 3 mm भी डालना पड़ता है single piece. Okay, so implant diameter is an important characteristic. Length as long as possible, obviously. Length has a lesser impact, so we would like to engage as much as bone as possible. So if I was to look at what he was saying, अगर मैं maxillary bone देख रहा हूँ, एक maxillary canine or say a maxillary premolar, I would like to place a implant which is as long कि वो inferior border of sinus को engage कर दे, because that is cortical bone, dense bone. I might like to engage that bone. Short क्यों डालूंगा? ऊपर का bone तो cancellous है, तो मैं cortical bone को engage करना चाहूँगा ना? Do you understand? Now we come to this surface. एक smooth surface या rough surface क्या better होगा? ये क्यों better है? Surface area increase होगा. That is one very good thing. Yes. Any other thing? Resistance नहीं. Surface area होगा. Obviously that area will allow more amount of blood to clot, blood holding capacity ना. तो volume बढ़ जाएगा. So that area will increase. The more amount of matrix will form, more amount of immature bone will form, and more amount of mature bone will form. That is why we like rough surfaces. Now rough surfaces can be created in two ways. One can be by using an abrasive, reducing something. ऊपर का surface को एक abrasive powder डाल के निकालते हैं, या हम ऊपर से कुछ ऐड कर देते हैं. It can be additive or reductive. Which is better? Reductive. Why additive is better? Additive reduces surface area और बढ़ रहा है. So additive was tried. So there were a lot of studies which we talked about. Hydroxyapatite को कोट कर देता हूँ ऊपर से, उसको मेल्ट करके मोल्टन फॉर्म में, उसको प्लाज्मा फॉर्म बोलते हैं, उसको बॉम्बार्ड करके ऊपर से एक लेयर्स बना देता हूँ. That's called a plasma sprayed implant. HA, plasma sprayed implant. What we normally saw, obviously hydroxyapatite and bone are similar. So the initial union becomes very good because they are similar tissues, they attract and they heal better. है ना? लेकिन over a period of time, what we saw, there were more failures because the bond between the HA we placed and the implant surface, the titanium, वो break हो गया. So we saw more and more failures there. There are still a lot of studies which are going on about pure titanium plasma sprayed. अभी वो टेस्ट हो रहे हैं, but not many are available right now. Most of the surfaces जो आपको मिलेंगे वो सब ज्यादातर reductive surface होंगे. अब वो reduction कैसे कर सकते हैं? Sandblasting can be one. Machining can be one. Machine surfaces. Anodizing can be one. Anodized surface हम ऊपर से उसका कुछ एक layer को by chemical means remove कर लेते हैं. Laser sintering, there can be various ways in which we can create those surface roughnesses. Okay. One more most common surface you will hear is something called as SLA surface. SLA. Acid etching can also be one. जो हमने नहीं बताया. SLA का full form आप कौन बताएगा? Sand blasted है S. अब चलो फोन का अच्छा यूज करते हैं. ऐसे ले ढूंढो, इसी बहाने फोन ये मिल जाएगा, तो फिर आप जा भी रहोगे. बस आई हैव टू फिनिश जल्दी से. मैं काफी स्ट्रेच कर चुका हूँ ना, मेरे 2 लेक्चर मिला. So sand blasted, large grip and acid etch. This is one of the most commonly used surfaces, which is being used in most of the implants nowadays. The good companies are coming with some nano characterization, nano level पे characterization कर रहे हैं. So expensive implants which you talk about. Now, would you like a hydrophilic or a hydrophobic surface? A hydrophilic surface will allow blood to directly form on the implant surface. Hydrophilic implants are more expensive. because they have to do additional surface treatments. If you do some laser sintering and you do some nano characterization, laser lock, a very expensive implant by Horizons. So all these are great characteristics which are being developed. What they do is they reduce time of osteointegration, enhance or encourage more forming. All these surface things will do that. Okay? So we'll just run through this. ये बहुत कुछ है इसके अंदर. If you want, I'll share this with you PPT. So as we said, we normally are using sand-blasted, large-grade acid etch. We do both sandblasting and acid etching in those surfaces. They are called SLA. सब जोर से बोलो. Very good. So these are various things which are done. You know this classification. Bone density की classification है मिश के अंदर. मैंने आपको बोला मिश पढ़ना है. हाँ? Best kind of bone या densest kind of bone कौन सा होगा? तो सारा पूरा cortical होगा. और worst कौन सा होगा? तो पूरा cancellous होगा. पूरा cancellous कहाँ मिलता है? Maxilla posterior area. That's the weakest, softest kind of bone. पूरा cortical कहाँ मिलता है? Mandibular anterior, mostly cortical bone. तो आप कौन से bone में ज्यादा खुश हो गए? Mandibular anterior. ज़्यादातर लोग वही बोलते हैं. Obviously इस conception वही आता है. लेकिन उसमें एक प्रॉब्लम होती है कि एक तो वैस्कुलैरिटी थोड़ी कम होती है, दूसरा ना इतना हार्ड होता है जब उसको ड्रिल करते हैं तो हीट प्रोडक्शन, जब हीट प्रोडक्शन हुआ तो आसपास के सेल बन जाते हैं. ऑस्टियोब्लास्ट तो चाहिए ना, 47 डिग्री सेंटीग्रेड से ऊपर गए तो सेल बन जाते हैं. सो वी हैव टू एंश्योर दैट यू हैव वेरी गुड इरिगेशन देयर, वेरी गुड इरिगेशन व्हेन यू आर स्पेशली डीलिंग विद वेरी डेंस बोन. तो there are, अभी जो मैंने शुरू में बोला था, पेशेंट से बहुत फर्क पड़ेगा. पेशेंट रिलेटेड फैक्टर्स बहुत इंपॉर्टेंट है. योर पेशेंट हेल्दी, if he or she is a diabetic, if he or she is a smoker, if he or she is medically compromised, then your chances of success also reduce. In that case, you have to make sure that other factors are very good. Body of the implant, surface, other characteristics are very good. A younger patient and an older patient, a younger patient obviously bone is healing faster. You would like to have a younger patient and success rate बढ़ेगा. अगर वो रेडिएशन थेरेपी में कैंसर चल रहा है तो बोन स्लो ग्रो करेगा कि फास्ट ग्रो करेगा. तो obviously chances of success will be reduced there. Very important to know. Very important. सर ने बोला कि हमें सर्जिकल प्रोटोकॉल बहुत अच्छा करना है. Sequential drilling मैंने एक वर्ड सुना था सर बोल रहे थे. उसका मतलब क्या है कि मुझे 4 mm का इम्प्लांट डालना है तो मैं सीधा 4 mm की ड्रिल से ड्रिल नहीं करता हूँ. पहले एक पतली सी ड्रिल डालता हूँ 1.2 mm, फिर 2 mm की करता हूँ, 2.5, फिर 3. तो उससे लीस्ट अमाउंट ऑफ परफेक्ट होता है. धीरे-धीरे उसको एनलार्ज करता हूँ. सेल डेथ मिनिमम होना चाहिए. दैट इज सीक्वेंशियल ड्रिलिंग. आई विल मेक श्योर अ लॉट ऑफ ट्रीटमेंट इज यूज्ड एंड द लीस्ट अमाउंट ऑफ सर्जिकल ट्रॉमा इज कॉज्ड. Cross that critical temperature of 47 degrees centigrade. If that is crossed, there is more temperature and the chances of
तो दिया सर
movement
घुमाएगा.
there are various measures in plant stability. We are not talking about that. We need, according to framework, we need the implant to be stable in the beginning when it is set. So we have to get primary stability. For that, we make a smaller hole, place a wider implant. Okay, that is the key criteria for framework kind of implantology. Essential है हमारे आज की understanding में. Over a period of time, this matures and becomes secondary stability. Absolutely clean implant surface. If your implant surface is contaminated, you're covering the titanium and you're not allowing it to heal. So make sure you never touch the implant surface. Loading, least amount of loading, least amount of trauma during healing time. When they will उसको protect करना है. तो कभी करेंगे कुछ लोडिंग जब बोन बहुत अच्छे से हील हुआ है, बोन बहुत हेल्दी है, पेशेंट हेल्दी है, सारे फैक्टर्स पॉजिटिव है, तो हम कुछ लोडिंग करेंगे, वो भी प्रोग्रेसिव करेंगे. पहले प्रोविजनल देंगे, अब पूरी लोडिंग कभी नहीं करेंगे. वो कब करेंगे? जब सेकेंडरी स्टेबिलिटी आ जाएगी. कब आएगी? 2 to 3 months के बाद. ठीक है? I think that's about my news. ठीक है? Thank you. Sorry, okay.
Thank you, sir, for making it so simple and palatable. So here we will break for 15 minutes. So don't go here and there. Washroom, water, इसके लिए, ठीक है? Don't exceed 15 minutes. Thank you, sir. And wait. So next lecture will be on anatomy, which is very, very important because you never learned it in first year. Okay? So it's kind of revision for you, which will help you in better understanding the basics, the dynamics that till now we have covered is all theoretical. That is all company aspect. The manufacturer is going to control all these variables in plant design, surface, and all that. Okay, so each company person will come to you. They will talk about all the good things about their plant. You should know what to look for. That sir has already told you. Now, what is more important